We have done the external oblique muscle. The second is the internal oblique. So we have cut the sagittal section of the abdomen to show the external oblique muscle fibers downward, forward and medially oriented. Where the muscle ends at this linea semilunaris, there start the aponeurosis of the external oblique. On coming the inguinal line, it is folded on itself to create a canal that is called inguinal canal. Seen from the front side, this is the skin. Then comes the superficial fascia, which was the Camper's fascia, that is the yellow color fatty layer, the Camper's fascia. But midway between the pubic symphysis and the umbilicus, there start the another layer, that is the Scarpa's fascia, which goes into the perineum as the Cooley's fascia. This is the Cooley's fascia. So this is the sagittal section. So we should have got the three-dimensional picture in mind. So this is the inguinal canal. Medial 4 centimeter of the convex inguinal ligament is called the inguinal canal. In the male, it contains spermatic cord, and in the female, it contains round ligament of uterus. So the anterior wall of the inguinal canal is formed by the aponeurosis of the external oblique. So they are the boundaries of the inguinal canal. Floor is formed by the concave part of the inguinal ligament. The posterior wall is formed by the reflected part of the inguinal ligament. So if you know this section, you can answer what is the anterior wall, what is the floor, and what is the posterior wall of the inguinal canal. So like external oblique, we will also go into the detail of the internal oblique muscle. So first is the origin. So origin of the internal oblique muscle is 3 point. Origin, this is the anterior-posterior view of the abdomen. The pubic symphysis in the midline, and above is the xiphoid process of the sternum, the body of the sternum, and this is the subpubic angle. So this is the pubic symphysis, laterally the pubic crest and the pubic tubercle. This is the start of the lower limb. Here lies the iliac crest, upper border with the inner lip, outer lip and the intermediate area, and this is the anterior superior iliac spine. So this is the thorax in the upper part, and here lies the costal cartilage of the 7th rib attaches here, then 8th fuses with it, then 9th fuses with 8th, and 10th fuses with the 9th. So 7th, 8th, 9th and 10th costal cartilages, they form the subcostal angle. So this is the ribs of the 7th, 8th, 9th and 10th. And here lies the level of the umbilicus. So internal oblique takes origin from, number 1 is from the thoracolumbar fascia. So we have seen the thoracolumbar fascia, that how it gives origin to the two muscles, transverse abdominis and the inferior. So with the coronal section, with the sagittal section, we should also know what is the coronal or the horizontal section of the abdomen. So when the abdomen is cut horizontally, it is kidney shape. The posterior concavity is because of the small spine of the lumbar vertebra where we can feel it, then the lamina, the transverse process, and anteriorly the large body of the lumbar vertebra, and this is the spinal or the vertebral canal is here. So here is the origin of the erector spinae muscle we have done. From the posterior surface of this transfer process, posterior surface of lateral surface of the lamina, and lateral surface of the spine is the origin of erector spinae muscle, covered by the posterior layer of the thoracolumbar fascia. Then it also takes origin from the middle layer of the thoracolumbar fascia. So posterior layer meet with the middle layer. Anterior to it lies the quadratus lumborum, which takes origin from the tip of the transfer process of the lumbar vertebra and a little bit from the anterior surface of the transfer process. So this is the vertical muscle, that is the quadratus lumborum. So quadratus lumborum posterior surface is covered by the middle layer, and anterior surface is also covered by the anterior layer. So anterior layer meet with the middle layer to form the thoracolumbar fascia, which is attached to the lower lateral 1/3 of the 12th rib. So posterior layer meet with the middle layer, then middle layer meet with the anterior layer, all three form the thoracolumbar fascia. We have done it. So that is the posterior view of the thoracolumbar fascia. So first origin is the thoracolumbar fascia, and direction of the fibers, they are opposite to the external oblique. So they are upward, forward and medially. So three words we use: upward, forward and medial. So from the posterior side they come on the, from posterior they come on the lateral side. So this is how we show in the coronal or the horizontal section. The internal oblique muscle, so fibers, they are going upward and forward and medially. Upward, forward and medially. But they cannot go beyond a line that is called linea semilunaris. So roughly it lies over here. Upward. So these are the thoracolumbar fibers. They are coming from back to front. Then second source of the origin of the internal oblique muscle fibers is from the intermediate area. Of iliac crest. So iliac crest has got three lips: upper, outer, inner and the intermediate area. So when the thoracolumbar fibers ends, then this intermediate area, the anterior 2/3, will give rise to the origin of the next muscles. So they are also in line with it. So they are from the middle or the intermediate area of the iliac crest. So all march same direction, upward, forward and medially. Third point of origin is from the lateral 2/3 of reflected part of inguinal ligament. So we have seen that how the inguinal ligament is the lower free border of the external oblique aponeurosis, and how it is folded on itself to become the reflected part. This is the reflected part of inguinal ligament. So this is the reflected part. So from the lateral 2/3, this much. So we divide the reflected part into three parts: lateral 1/3, middle 1/3 and medial 1/3. So the internal oblique takes origin from lateral 2/3. Underline it, lateral 2/3. So when the iliac crest ends, the next fibers they take origin from lateral 2/3 of the. Is it clear? So all are marching upward. So this is the 3-point origin you have to remember. Now comes the insertion. So this is how we show here the origin of internal oblique. Opposite to the external oblique fibers from reflected part. This is the sagittal section, this is the coronal section. So insertion number 1, the inner surface of the 7th, 8th, 9th and 10th ribs, lower 4 ribs. So the uppermost fibers, they go inside the ribs and they are inserted on the inner surface of the 7th, 8th, 9th and 10th ribs, like this, inside. So that is insertion. The uppermost fiber coming from thoracolumbar fascia, they gain insertion. Then subsequent fibers, so they are the green is the aponeurosis of internal oblique muscle. So first insertion is the inner surface of the lower 4 ribs. Number 2 insertion is the split into 2 layers, anterior and posterior. So unlike the external oblique, so this was the Camper's fascia. After that we have done the external oblique muscle having the direction of the fibers and how it is created the superficial inguinal ring which is triangular, and this was the reflected part of the inguinal ligament. So in this behind the superficial inguinal ring there comes the reflected part of the inguinal ligament fibers. So these fibers, they somehow prevent the occurrence of the hernia through this. So this is how the reflected part is coming behind the superficial inguinal ring. So this is the internal oblique muscle. So the fibers, they are upward, forward and medially going up. So the uppermost fibers, they go inside the ribs and inserted on the 7th, 8th and 9th ribs. Then these lower fibers beyond the linea semilunaris, they form the tendon. That green is the tendon of the aponeurotic tendon of the internal oblique. So note it that the aponeurosis, unlike the external oblique, it's split into 2 layers. External oblique was having only 1 layer, but it's split into 2 layers, anterior and posterior 2 layers. Why 2 layers? We will discuss later on. So after the rib insertion, the lower fibers, they split into 2 laminas or 2 layers and they insert over the opposite fibers and they constitute what is called linea alba. So linea alba is not the property of the external oblique. So internal oblique aponeurosis is also fused with the linea alba, superiorly with the tip of the xiphoid process and inferiorly the pubic symphysis. So both are fused, both are overlapping each other. So this is how we do the X. Then, so this is the second insertion. Third insertion. Now the lowermost fibers of the internal oblique, So they are the lowermost fibers. The brown one. From where they are taking origin? From the intermediate area of the iliac crest. So the iliac crest, the outer lip, so this is the intermediate area. Dotted means intermediate area. So their fibers, they also form the linea alba. Then the third point of origin was from the lateral 2/3 of the reflected part from here. So the third point of the origin muscles, they take origin from the lateral 2/3 of the reflected part of the inguinal ligament. So these are the third point origin of internal oblique. So the lowermost fibers, the internal oblique, they do not run horizontally, but they curve downward, forward and medially. Which fibers? Lowermost fibers. They go downward, forward and medially to gain insertion into some bone, that is the pubic crest. To the pubic crest. Because muscle, they want the firmness. They form the stability. When a muscle is stable, when it is attached to some bone. So if they do not curve downward, or they would have been straightway go like from right to left here, so below this line, the muscle was weak. It is hanging in the air. So in order to gain the firm insertion and anchoring, so these fibers, they curve downward towards the pubic crest. And they get insertion into it. They get attachment into it. So when the lowermost fibers, they curve downward, so this curved part of the lowermost fibers of the Abdominis of the internal oblique is called the arcuate line. So this line is arc-like, so it is called the arcuate line, and this medialmost part of the Abdominis of internal oblique, which get inserted into the pubic crest, that is from pubic symphysis to the pubic tubercle, this part, this is called the conjoint tendon. So in my hand I am holding the conjoint tendon. That is the insertion of internal oblique into the pubic crest. Is it clear? So this is how we do the 3-point insertion of the internal oblique, that is into the pubic crest. And part is called conjoint tendon. So how we show in the coronal section, so where the brown ends, muscle end, lemina seminalis, they start the aponeursis. But it divided into two laminas, anterior layer and posterior layer. So in the coronal section, the outer layer is the skin. Below the skin is the superficial fascia, which is the Camper's fascia. The yellow color fat below the skin, circumferential below the everywhere in the body. So skin and the superficial fascia, how you can show in the coronal section of the abdomen. This is the same diagram which we see in the CT scan or in the ultrasound. All are slices of horizontal or coronal section of the abdomen. Then below the cerebral fascia there lies the external oblique muscle. This is how we show it. External oblique muscle, and beyond this is the aponeurosis of external oblique. And here right meet with the left to form the decussation, that is the linea alba. So here also anterior and the posterior layer, they meet in the midline and they attach to linea alba. Same is happening on the other side. Is it clear? What is the coronal section? So you should have got the three-dimensional picture in mind. How it looks sagittally, coronally, and antero-posterior. Then only you can understand it better way. So this is the linea alba, the fusion of the midline by the appearance of external oblique and the two laminas of internal oblique. And how we show here the lowermost fibers. So they are the linea alba. So split into two lamina, anterior layer and posterior, both meet in the midline to form white line of the abdomen, that is the linea alba. So only the lowermost fibers, they arc downward medially in front of the reflected part and has been inserted in pubic crest. So hence a arc shaped line is created. This is called the arcuate line, and this is called the conjoint tendon. And this is the arcuate line. The other name of the conjoint is also called Falx inguinalis. Falx inguinalis, as we have done the falx cerebri. Falx cerebri is a vertical fold of the dura mater which separates the two cerebral hemispheres. So it also looks like the dura mater sheet. If you hold it, it is like the exactly like the dura mater. It is also vertical. So that's why his name is Falx inguinalis. Now this arcuate line is always crossed by the artery with vena commitans. The artery is called the inferior epigastric artery. Now inferior epigastric artery is the branch of the external iliac artery. External iliac has got only one branch. Remember, underline it. External iliac artery branch is the inferior epigastric artery. Only single branch is there. While the internal iliac artery has got 12 branches. But external is only having one branch. So this is called the inferior epigastric artery. So it always crosses the arcuate line. And this artery goes into the two layers of the internal oblique and running upward to meet its fellow, which is the superior epigastric artery. And superior epigastric artery we have done in the thorax, which was the branch of internal thoracic artery. Internal thoracic artery. We have seen in the thorax the internal thoracic artery, which is also called internal mammary artery, because it supplies the breast in the female. So in the sixth intercostal space, this internal thoracic artery divided into two branches, lateral branch and a medial branch, which is the continuation of the internal thoracic artery. It comes below the seventh costal cartilage and enters into the two layers of the internal oblique, and they meet anastomosis here in the two layers of the internal oblique. So this superior epigastric artery is the branch of and continuation of the internal thoracic artery. The lateral branch is called musculophrenic. You have recently done the blood supply of the diaphragm. So peripheral part of the diaphragm is supplied by this artery, that is the phrenic branches or diaphragmatic branches of the musculophrenic. Phrenic means diaphragm. So it supplies the intercostal muscles plus the diaphragm. That's why his name is musculophrenic artery. So that is how the superior epigastric artery enters into the two layers of the internal oblique, which are inserted into the lower four ribs. So this is how it is. Now because of this artery a small oval area is created. A oval area is created here. This oval area is called the deep inguinal ring. Like superficial inguinal ring is the gap in the external oblique aponeurosis. So deep inguinal ring is related to the internal oblique muscle. What is the boundary of this oval foramen? Superficial was triangular. This is a oval aperture or the foramen. So superior boundary of this deep inguinal ring is what you will write? Arched fibers of the internal oblique, which are going to form conjoint tendon. Lowermost fibers of the internal oblique. And who is forming the floor? Upper free border of the reflected part of inguinal ligament. What is this? Upper free border. This muscle is only taken away from the lateral 2/3. So medial 1/3 is free. So this forms the lower border or the lower boundary of the deep inguinal ring. And who is forming the medial boundary? Inferior epigastric vessels. That is the artery accompanied by two vena comitants. So this is how we do the deep inguinal ring. So the inguinal canal between the deep inguinal ring laterally and superficial inguinal ring medial is called the 4 cm. It is only 4 cm distance between the two. If you measure, this is called the inguinal canal. This is called the inguinal canal. So how we show in the model? So this is the internal oblique taking origin, the muscle fibers, and these are the inferior epigastric vessels with the vena comitants. So between the two and here lies the So this is the inferior epigastric vessels which are crossing the arcuate line. So this aperture lateral to the inferior epigastric vessels, two vena comitant and the inferior epigastric artery. So my finger is in the deep inguinal ring. Is it clear? So vessels, they forming the medial boundary. So from this point to the superficial inguinal ring, if you overlap both them, so this measures only 4 cm, only this much. So that is called the inguinal canal is there. So that is how we do the deep and the superficial inguinal rings. Now comes the third muscle, that is called the transversus abdominis. Transversus abdominis muscle. As the name is suggestive, transverse abdominis is transversely running, horizontally running fibers, and like all others, it is also having the origin, insertion, So remember, the transverse abdominis has got 4 points of origin. External oblique was having 1 point of origin. Internal oblique was having 3 points of the origin. The transverse abdominis has got 4 points of origin. So number 1 origin is from the inner surface of the 6th, 7th, 8th, 9th and 10th ribs. And muscle fibers, they are horizontally running, transversely or horizontally running fibers. So uppermost fibers, they take origin from the inner surface of the upper ribs, and they cannot go beyond the linea semilunaris. Beyond this start the aponeurosis, and this aponeurosis reaches at the level of the xiphoid process. So here right meet with the left, and what they constitute? Linea alba. So linea alba is the insertion. So origin is from the ribs. Second point of origin is from the thoracolumbar fascia. So like internal oblique, this muscle also taken from same thoracolumbar fascia, transversus abdominis. Third point of origin of the transverse abdominis is from the iliac crest. Outer lip was for external oblique, intermediate area was for internal oblique. What is left? So inner lip, anterior 2/3 is made for the origin of transversus abdominis muscle. So that is the third point origin, the inner lip. Of iliac crest. The fourth point origin. So fourth point origin is from the lateral 1/3 of the reflected part of inguinal ligament. So internal oblique was from lateral 2/3, this much. But transverse abdominis, it takes only from the lateral 1/3 that you have to underline. There is a confusion between the lateral 2/3 and lateral 1/3. Usually student, 90% of students, they muffle here and they give the opposite answer. So write down lateral 2/3 is for the internal oblique and lateral 1/3 is for transversus abdominis. Lateral 1/3. Reflected part of inguinal ligament. So this is the reflected part. So how you can show here in the central section, this is the transverse abdominis, transversely running fibers. Is it clear? So this is how. So inguinal canal, anterior wall is formed by the aponeurosis of the external oblique. Floor is formed by the concavity of the inguinal ligament. Posterior wall is formed by the reflected part of the ligament, and roof. Who is forming the roof? Arched fibers of internal oblique and transverse abdominis. So that is the. So this small area is clear. What is inguinal canal? All boundaries are given. So never confuse. If you know this diagram, lowermost part, you can answer any part. So then comes the insertion of transverse abdominis. Regarding insertions, as we have seen that the uppermost fibers, so the uppermost fibers, they get inserted into the xiphoid process and linea alba, uppermost, both above the umbilicus and below the umbilicus. The lowermost fibers, like internal oblique, they also arc downward. to get insertion into some bone, and bone is the same for the internal as well as the transverse. That is the pubic crest. So the uppermost fibers, they are inserted into the linea alba, right with the left, and secondly to the pubic crest. And it also forms the lowermost fibers of the transverse abdominis. They also form, like the internal oblique, the arcuate line. So arcuate line is the combination of both the lowermost fibers of the internal oblique as well as the transverse abdominis. Lowermost fibers. And insertion of them is also very common. The lowermost fibers of transverse and the internal oblique, they are all joined together to be inserted into the pubic crest. And this is the reason why we say the insertion of the lowermost fibers as the conjoint tendon. Co-joint tendons, tendons of both internal and transverse. Now I am holding the, what is I am holding? Conjoint tendon. What it contains? Two laminas of internal oblique as well as single lamina of transverse abdominis. So this is the conjoint tendon, fused with the pubic crest below. So it is clear. So that is how we should the internal oblique and transverse abdominis. So this is again the appearance of the transverse abdominis, and here right meet with the left, decussation which fuse with the linea alba. So linea alba is not the property of the internal oblique or external, they are all combined. It is formed by the fusion of three aponeuroses of three muscles. So this is how we do the insertion. And the inferior epigastric and superior epigastric vessels along with the vena comitants are lying on the posterior layer of the internal oblique aponeuroses. This is the anterior layer, this is the posterior layer. This is how we show diagram. So this is how our anterior abdominal wall is constructed by three curtain-like muscles, the external oblique, internal oblique and transverse abdominis, but they are all lateral to the linea semilunaris. So if any injury is there, external injury to the abdomen, so no abdominal organ is injured, because the muscles, they are shock absorber. They will protect the internal injury. But the area of the anterior abdominal wall between the two linea semilunaris, from here to here, this strip is a weak point, because there is only the aponeurosis of external oblique, thin fatty layer, thin skin, and these four layers, they are also very, very thin. When you do the dissection, you will see they are more thinner than your paper. These aponeuroses, they are very, very thin, paper-like, more thin than paper. So they can't protect the external injury. So what is the solution? Two muscles, rectus abdominis and pyramidalis. Rectus abdominis and pyramidalis. As the name is suggested, rectus abdominis is a abdominal muscle, which is, rectus means straight, it is a straight muscle, and second is the pyramidalis means it is a pyramidal shaped muscle. So both are vertical muscles, and they are lying between the two linea semilunaris. And what exactly? The rectus abdominis, it lies more specifically in the two layers of the internal oblique. So this is the situation. Is it clear? And in the lower part, pyramidalis lies medially in front of the rectus abdominis. So now, if injury is here, three muscles are protecting. If injury is in the front part, muscles are protected. So this is how the anterior abdominal wall is made injury proof, shock proof by these two vertical muscles, rectus, abdominis and pyramidalis. Now come the 5 points of abdomen muscle, origin, insertion, action. So rectus abdominis muscle takes origin from the pubic crest. So pubic crest, if you see the pelvis or the hip bone, it is about the thickness of your finger. So conjoint tendon is also attached here. Pyramidal is also taken origin from here. Rectus abdominis also takes origin from this. So it is about 1 centimeter broad if you see from the upper part. So that is how it is. And this rectus abdominis muscle is taking origin, then where is the insertion? So origin is very narrow, but as the muscle going upward vertically, it becomes broad and it is inserted on costal cartilages, not ribs, underline, costal cartilages of 5th, 6th and 7th ribs. It runs upward, and where it runs? In between the two layers of the apparatus of the internal oblique. Now this is the answer why there are internal oblique is having two splits, two layers, because to accommodate the two muscles, internal oblique and transversus abdominis. So this is the rectus abdominis muscle. Straight muscle, vertically running fibers. And this is the internal thoracic artery dividing into musculophrenic and superior epigastric with vena comitans, and this artery runs over the posterior. It is stick to the posterior surface of the rectus abdominis. When we do the dissection, you will see it. It is stick to the posterior surface of rectus abdominis, and inferior, what is coming? Inferior epigastric artery. So posteriorly, all the vena comitants and the superior and the inferior epigastric artery, they anastomose. Plus they supply this strong muscle rectus abdominis. So in the people who go into the gym, they know what is the role of the rectus abdominis. It keeps our belly flat. All exercises for the flattening of the belly depending upon the strengthening of this rectus abdominis muscle. The exercises, they are called rectus exercises. So where it is inserted? In the 5th, 6th and 7th costal cartilage. See, it is becoming broad and it is going up. Below it is narrow. And in front of it, there is a pyramidal shaped muscle. This is called pyramidalis. So it is only present in the lower part. In some people, it may reach up to the umbilicus. In some people, it may end in between the umbilicus and the pubic symphysis. In some people, it may be absent unilaterally or bilaterally. So there are multiple variations are there. So it is a very vestigial type of the muscle is there. Its absence doesn't have got any ill effect on the anterior abdominal wall. Actually, this muscle was made for the suspensory muscle of the penis in the male, but it has got undergo rudimentary with the evolution, or it has degenerated. So this is how the rectus abdominis. So now this is the answer. So this rectus abdominis is accommodated in the two layers of internal oblique muscle. So it is very comfortably is lying in the two layers of the internal oblique. So this is how we do the internal oblique. So it is present here. All the other epinosis, they are all in front of the rectus abdominis muscle. So when we cut and see all these muscles and remove them one by one as a layers, now what is the next we see in the abdominal cavity is this yellow color fascia. This is called fascia transversalis. This is the fascia transversalis. Behind the transversus abdominis muscle, we get a layer of the muscle, the layer that is called fascia transversalis. It is also circumferential. Fascia transversalis. Now this rectus abdominis muscle at the point of origin, its posterior surface of rectus abdominis muscle is touching the fascia transversalis, and the conjoint tendon, it lies below the arcuate line. Anterior to the rectus abdominis, meaning thereby from the pubic crest upper border, posterior most is the origin of the rectus abdominis, anterior to it is the pyramidalis, and anterior to this is the conjoint tendon. So that is the arrangement you must know. So conjoint tendon is anterior, then pyramidalis, then rectus abdominis. So all the three muscles, that is the transverse abdominis, they are all lying anteriorly. So the posterior surface below the arcuate line is the fascia transversalis. If you remove this fascia transversalis, you will get another layer in the abdominal wall, anterior abdominal wall layer. This yellow color fatty layer. But it is much thinner than the campus fascia. So this is the called fascia transversalis. This is the fascia transversalis. Then this is called the extraperitoneal fat. It is called the extraperitoneal fat. And when we remove this extraperitoneal fat, the final layer of the anterior abdominal wall formation is the peritoneum. This is the peritoneum. Is the peritoneum. So any bullet injury, when it has to damage any abdominal organ, has to go through these obstacles of the anterior abdominal wall. As we have done the 4 B's for parotid duct. So see how many obstacles are there. Number 1, number 2, campus fascia. Now you will say in the abdomen never use the word superficial fascia. Campus fascia, and if it is bullet in the lower part, the third layer will be scarpus fascia. Fourth layer will be epinosis of external oblique. Fifth will be internal oblique. Then sixth, then seventh, then eighth is the fascia transversalis. Then ninth is extraperitoneal fat, and then 10th is the. So anterior abdominal wall from the skin to the peritoneum has got how many layers? 10 layers. So that is called the bullet injury after going through all these 9 obstacles. Some are thick, some are thin, but no doubt all are having 10 layers of the anterior abdominal walls are there, starting from the skin, campus fascia, scarpa fascia, appearance of the external oblique, conjoint tendon or the internal oblique fibers. Then comes the fascia transversalis, then comes the extraperitoneal fat, and then comes the peritoneum. So this is how we can show in the sagittal section. And this is the coronal section. Is it clear? So whenever in the exam you can't make this diagram, you have to practice only this much. This is easy to make. Is it okay? You can easily make it skin, campus fascia and apollonosis surface. So you have to practice this. Maybe unilaterally that is sufficient. You are not to make bilaterally because everything is bilateral symmetrical. So half is enough. So why to waste time in the examination if you are making two sides? So save the time in answering the diagrams and questions. Don't make bilateral anything. So even the face also, head and neck, don't make whole front of the face. You make the side of the face. Practice the side of the face. Only one side of the muscles, facial vein, dangerous area of the face. Any diagram of the face should be one sided. So there is a wastage of the time of the making bilateral. Then last part is the nerve supply. Rectus abdominis nerve supply, as it goes upward, inserted over the 5th, 6th and 7th ribs, like this. So they are supplied by the intercostal nerves. As we have seen in the skin also, intercostal nerves are supplying the skin. What was the nerve number at the Ziegfeld process? T7, 8, above the umbilicus 9, below 10, 11. Same you have to remember. Anterior to rectus abdominis, this is pyramidalis. So remember the diagram of the intercostal nerve. Spinal nerves, the branches, sympathetic ganglion, thoracic with grey ramus and the white ramus communicans. They are called the communicating or ganglionic branches. Then it has got the lateral cutaneous branch, dividing into anterior and the posterior branch. Then it has got the anterior cutaneous branch, dividing into medial and lateral, supplying the skin of the over the sternum. Same intercostal nerve gives a collateral branch. This is a muscular branch. It supplies the external, internal and intercostal muscles. On the same pattern, ribs, costal cartilage is the end of the thorax plus end of the intercostal muscles. But the nerve is very long. It has to reach the midline, starting from the intervertebral foramen of the spinal cord. So beyond this, the nerve goes here, T7, T8, T9. So these nerves are marching obliquely. Same vein relation, vein, artery and nerve, as in the costal group. After supplying the intercostal muscles of the spaces, same artery, vein and nerve, they are now entering into the abdominal, anterior abdominal wall. So they will supply so they lie between the external oblique and the internal oblique muscle. And they supply external oblique muscle as well as internal oblique as well as transverse abdominis as well as rectus abdominis. So the muscular branches has got so many branches. So this is the motor branch. This is the sensory branch, this is the motor. M for M, supply the muscle. So this nerve will supply T7, T8, T9, below the umbilicus T10, T11, and last is the T12, that is the subcostal nerve. So subcostal nerve supplies the pyramidalis muscle, underline it. Nerve supply of pyramidalis is T12 because it is the lowest. Nerve is lowest and the muscle is also lowest. The rectus abdominis is supplied by from T7 to T11. See this diagram. And the nerve enters the lateral border of the muscle, rectus abdominis. It enters from the lateral border of the muscle, supplies it, and then comes from its medial border. After supplying the muscle, the same intercostal nerve comes out of the medial border, and then it becomes sensory and supply the skin of the from xiphoid process to the pubic symphysis, or skin over the linea alba. So that is the fate of the all intercostal nerves after thorax. So that is the nerve supply from lateral to medial border of the rectus abdominis muscle. Now the last question about this anterior abdominal wall usually asked in the examination is the rectus sheath. Rectus sheath is the covering. As you have done the carotid sheath. So carotid sheath is a sellotape around the internal and the common carotid artery, internal jugular vein and vagus nerve. Same is this. So rectus abdominis muscle is covered by the coverings, anterior and posterior is called the rectus sheath. So we have seen that how the rectus abdominis muscle is accommodated in the two laminas of the internal oblique. So whatever layer lying on the anterior side will be the anterior layer of the rectus sheath, and what is to behind is the posterior layer. So if you know this diagram and this, you can answer what is the rectus sheath. So rectus sheath is nothing but this is the covering of the two muscles, that is the rectus abdominis and pyramidalis, and two layers are in front and two layers are behind. Anterior wall is formed by the aponeuroses of the external oblique and anterior layer of internal oblique. Posterior layer is formed by the posterior layer of the internal oblique aponeuroses and aponeuroses of the transverse abdominis. So two, and so this is, and what are the contents of sheath? Two arteries, two veins, two muscles. Two arteries, superior and two nerves, veins, same, accompany, superior and the inferior epigastric vein, and two muscles, pyramidalis and, so that is how we. So this is in a nutshell what is our anterior abdominal wall is formation. Rest of the applied and other things we will do in the next class.